Hello, welcome everyone. We're so excited to offer this opportunity for learning. We are excited to have this conversation today with some esteemed panelists. So we look forward to that. Just want to let everyone know that this session is being recorded and we will be sharing some resources through our Javi channels. You can follow the Javi on LinkedIn, Instagram, or visit our website for more information about the Javi. I am Tony Rivera. I am the Managing Director for Communities of Practice at the Javi. In that role, I oversee the legacy work of the Javi, which includes the annual conference. It includes our membership network and our peer offering learnings, as well as our work around the CVI ecosystem and supporting our frontline. So welcome, welcome, welcome. In my time being involved with the Javi, I also led a flagship HVIP program in Milwaukee, Project Ujima, for 10 years. So that is the space in which I come into this work. And while I was at the Javi, I'm sorry, at Project Ujima, also participated as a founding member of what is now the Javi as an organization. The Javi's mission is to reduce violence, particularly in communities of color, by advancing hospital violence intervention programs and coordinated community-led systems to promote healing from trauma and promote equity. When we say HVIP, what does that stand for? I want to be clear that we all are level setting here. HVIP stands for Hospital Violence Intervention Program, and how they work is the hospital has staff that report to the hospital as soon as someone comes into the hospital that has been violently injured, providing training to frontline staff that then respond to the needs of those injured at the hospital provides a golden opportunity for an intervention to happen at bedside when families and individuals need it the most. The Javi has been elevating the work of HVIPs in the violence intervention field across nationally in several different ways. The one way that the Javi has worked to unite and uplift the work of HVIPs was through the release of our standards and indicators. Our standards and indicators is the framework for which we support our HVIP programs from the beginning, when it's just the thought of having an HVIP, all the way through funding and sustainability, long-term in support of the HVIP. The Javi's role in supporting HVIPs is providing training and technical assistance to HVIP programs across the country in a variety of different ways that supports them in long-term sustainability. I am going to now introduce the moderator for our panel. Kendra has over 25 years of experience in the CVI movement. As the Senior Director at the Javi, she leads Javi efforts to support HVIP's integration in the CVI ecosystem. She oversees the VPP training and certification program, as well as our Empowering the Frontline working group. Previously, she directed programs at Youth Alive in Oakland, empowering violence-injured individuals, and where she led a violence intervention team. Kendra holds a PhD in community psychology and degrees in psychology and a bachelor's and a master's. And Dr. Kendra Simmons, I'm handing it over to you.
Thank you, Tony. Thank you. And welcome to our first webinar. For those who may have just joined, I want to just again give another reminder that this webinar is being recorded. And the resources again will be shared through our Javi channels. I'm so excited to have you all here. This is great. Be sure to follow us on LinkedIn, Instagram, and visit our website for more information. Quickly, our objectives for this webinar is really to inform the field and you all about really what the role is of HVIPs in the CVI ecosystem. So we really want to talk about strategies for HVIPs partnerships in order, really to talk about how the HVIPs interact with other models and potentially discuss some case studies. We want to present some challenges, some lessons learned, and local best practices to partner again with other CVI models and stakeholders in the CVI ecosystem. So first, we'll go over some basic concepts really to level set our conversation and have some understanding around what we really mean when we talk about the CVI ecosystem, and really have some better understanding and really make some references about like what it is when we talk about HAVI standards and indicators, so we really understand how our HVIPs are adhering to our standards and indicators while we're actually building partnerships and really working with our stakeholders within the CVI ecosystem and working with other CVI models. So first, before I welcome the speakers, I want to really get into talking about HVIP models and really describe these the three HVIP models. So first, I'll talk about hospital-based HVIP models. So when I talk about hospital-based violence intervention programs, these models are entirely housed within the hospital. So that means that everyone who is working within this hospital-based violence intervention program, they are employed by the hospital. So the frontline workers are actually employed by the hospital, the program coordinator, all of the staff, everyone working within this hospital-based program is employed by the hospital. So that is what we mean when we say a hospital-based program. And so then there's also hospital-linked programs. And so with a hospital-linked violence intervention program, this means that the hospital has really built a relationship with a community-based partner, which means that there are MOUs in place. So those memorandums of understanding are critical when you have a hospital-linked program, because we know that there is HIPAA, and so we cannot forget about that. So we want to make sure that the hospital has consent from those who are violently injured for a community-based organization to be granted access to come to the hospital, to really have that partnership and speak to violently injured patients at the bedside. So make sure that they have that accessibility coming into the hospital. And also it helps to support and protect frontline workers when they are entering the hospital. So make sure again that there is a clear partnership there. So it's great to have those memorandums of understanding in place. And so then also we have a hybrid model. And so with a hybrid model, you can actually have hospital staff and also community staff that are also working together. You still need those memorandum of understanding, but then you have those who are employed, again, some in the CBO, some within the hospital, but they're really having a strong partnership and working together to really have a hybrid model. So their program has folks working in the community-based organization within the hospital, but their program really works together. So they're not considered a linked model. For example, we will hear from some of the panelists later who actually have a hybrid model where they may have some of their staff employed within the CBO and within the hospital coming together. So I just really wanted to make sure that before we hop into this panel discussion, that we are clear on what these models look like. Next slide, please. Thank you. So the goal of hospital-based violence intervention programs, and a reason why I wanted to really level set and be clear on what those models are, because when we say hospital-based violence intervention program, one may want to believe that we're only talking about those models that I mentioned, where those are all employed by the hospital, because again, hospital-based violence intervention programs will lead you to believe that we're only talking about that one model. So no, we're talking about those three models when we say that hospital-based violence intervention program, but we're talking about HVIPs. And so the goal of HVIPs, whether it's a hospital-based model, a hospital-linked model, or a hybrid model, the goal of an HVIP, we want to promote individual and community healing from trauma. Because we all know when one person is injured in the community, it affects the community. That violence, it spews across the community when you see it, when you hear about it. We know that. So we want to promote the individual healing, but also the community, the healing that needs to happen for the community. We want to reduce retaliation and re-injury and arrest. We want to make sure that folks can actually heal and lead productive lives. And we want to stop the cycle of violence and trauma that ravages Black and Brown communities. We know what happens in communities, especially when this violence, community violence, continues to penetrate communities. So we want to stop that cycle of violence. And then also we want to help those affected by violence. We want to make sure, and I just said that, to lead healthy and productive lives. We want to ensure that folks can heal from trauma. And then again, address the root causes of violence and despair, the structural violence, those inequities, those things that lead to policy change. And we want to make sure that we support folks in doing that. And again, making sure that our HVIPs can be a voice for folks who normally would not have a voice. Next slide, please. And so now, the million-dollar question: what is a CVI ecosystem? And so then I want to take folks to sit for a second and really read this. I'm going to read it out loud, but I want you all to really absorb this. What is a CVI ecosystem? Because it takes everyone. It's not one model, and it's just not one person. It's not one entity. It really is going to take all of us to really come together and really take ownership of our CVI ecosystem together, collectively. What is a CVI ecosystem? A CVI ecosystem is driven by leadership. It connects a city's violence prevention infrastructure, including community-based organizations, offices of neighborhood safety, and public health departments that too often work separately in order to implement a comprehensive slate of strategies that address violence dynamics. The goal is to provide adequate funding and coordination with a shared vision of public safety to maximize the response to high-risk people and to make violence reduction sustainable. So again, we want to make sure that a CVI ecosystem is coordinating all of the services and the funding that is needed to continue to reduce community violence. We want to make sure that stakeholders and everyone who is involved, that we continue to ensure that when you have a strong CVI ecosystem, including HVIPs and all of the other models that are involved, that this continues to happen, the continuum of reducing violence, specifically community violence, that continues to happen. We don't want this to be a one-time thing, or that it only happens for a short period of time. We want to make sure that the CVI ecosystem continues to support the reduction of community violence. Next slide, please. All right, primary CVI ecosystem strategies. You have crisis management systems, you have street interventions that include violence interrupters, street outreach. Those are folks on the ground every day doing great work. Peace fellowships like Advanced Peace, gun violence reduction strategy, targeted trauma-informed care. That's across all models. So we want to make sure that folks are really using a trauma-informed approach. And then also hospital-based violence intervention programs. And who's coordinating these? Who's around? The offices for violence prevention. They are at the table, and they're coming up in every city. So we want to make sure that offices for violence prevention, they're included in this. And then again, support services, substance abuse, mental health, victim services, support for families. So we want to make sure that we include those support services, because again, those are needed within the CVI ecosystem. So we want to make sure, again, that these are the services that are needed within the CVI ecosystem. And then also, you have those support services. So we have to ensure that we have folks at the table. We have our primary strategies, but we have those folks at the table who provide those supportive services. Again, the CVI ecosystem has primary strategies, but you need those support services to offer to those who are at the highest risk, and also those who need additional support. We cannot do it all ourselves. Next slide. All right, I'm going to get in and start announcing these amazing panelists. I'm going to get in before I start talk and ask questions, I want to first introduce Christine Gogans. She's a licensed social worker focused on addressing root causes of housing insecurity with 17 years of experience. She leads the violence recovery efforts at UC Chicago Medicine, is a national leader in hospital violence intervention programs. So, without further ado, I am going to hand it over to Christine.
Thanks, Kendra. So, hi, everybody. I'm here to tell you about the amazing work that we're doing at U Chicago Medicine. So, the Violence Recovery Program is a hospital based intervention program located on the south side of Chicago. So, our story is really began back in the 80s, but our level one trauma center was closed. But then in 2010, there was a local activist. His name was Damian Turner, who was shot about maybe 2 blocks away from University of Chicago Medicine. And because it wasn't a level one trauma center, they tried to take him to Northwestern Hospital, which is about 8 miles away. And unfortunately, he passed away in the ambulance on his way there. And his family was adamant that if there was a level one trauma center at University of Chicago Medicine, that this wouldn't have happened, that it could have, his death could have been prevented. And this was the atmosphere of the entire city at the time. So the reopening of our trauma center was very much so community led. A lot of people did a lot of protests and a lot of sit-ins to demand that our level one trauma center was open. And so on May 1, 2018, our adult trauma center was reopened and we started servicing children as well as our adults again. And so for our program, you can go to the next slide. We provide case management and crisis intervention to our patients and families immediately when they come into the trauma bay, and we support them throughout their inpatient stay. So we work with patients that have been injured by all forms of violence. So whether that is gunshot wounds, stab wounds, sexual assault, domestic violence, even when people intentionally hit someone with a motor vehicle, we service all of those patients. And our goal is to reduce the reentry risk and promote comprehensive recovery. We know that we are intervening when people are injured, so we're trying to reduce the chance that they're re-injured again and providing them with the resources that they need to make a full recovery. So our crisis intervention work, that begins in the emergency department. And so we're at bedside with our patients, telling them like, we know that this happened to you. Let's get you connected to your family or your loved ones as soon as possible. Let this get them a medical update, because we all know what it's like when you show up to the hospital and you want to know what's going on with your loved ones. So we get paged just like our trauma surgeons and the medical team, and we respond over to the adult and the children's emergency departments. So in that space, we start off by collecting information, being a supportive presence, and starting to address any safety concerns and just meeting basic human needs. This work is human work. It's heart to heart, human to human. And we're just trying to be there to alleviate the stress that the patient is experiencing and that their loved one is also experiencing. So we operate out of the frameworks of psychological first aid and trauma informed care. So, and we work within teams. As you can see right here, our team approach is really multidisciplinary in nature. So we work with social work, we work with child life who supports our youth, we work with chaplaincy, public safety, and community organizations to provide that ecosystem of support around our patients and our families. And for our patients, we see about maybe 1,500 to 2,000 patients each year. We have a really large volume, and we're not proud of that, but we're trying to do everything that we can to get that down. Our highest volume was in 2021, where we saw over 2,100 patients. And people that aren't familiar, 2021 was just a hard year for everybody in violence prevention and intervention. We really hit like record numbers across the nation. With our patient caseload, the highest form of violence is gun violence in the community setting, and Black males are injured the most. And so for our patient population, about 50% of our patients are discharged directly from the ED, and 50% are inpatient. They stay for an extended period of time. And so we have a team of about 30 now. That includes our frontline workers, the team leads, our inpatient team, and our outpatient team. So our inpatient team, they see to our patients at bedside daily, and they're assessing our patient for needs, assessing for safety concerns, and then starting to figure out what interventions and referrals they need to do for that patient to make a full recovery. And then our outpatient team, they work with our patient population that discharges directly from the emergency room, so that we're capturing those people who are like, we're just there for moments, but we still want to follow up because that's a large part of our patient population. And so our case management is that we're documenting the needs, we're making those interventions and referrals, and we're helping our patients have a comprehensive recovery. What I love about our case management is that it's very individualized to what the patient needs. So we're holding a patient's hand throughout their time. Medical care comes first. So in the hospital setting, you want to make sure that they're healing from their injuries and that they have support. And so we're holding their hands and on their timeline. So if a patient wants to work on employment, or they want to work on just getting home care afterwards, we're there to help them with whatever goals that they want to work on the timeline that they want to work on, and for however long that they need us. Some people will say, well, I just need you for tomorrow, just give me a call, check on me. And some patients we've worked with over 2 to 3 years at a time. So it really just varies, but I love that our approach is very individualized, so you can address those very unique needs. And you can go to the next slide. And we have also grown, and we talked about this already, just addressing the structural barriers. You have to address the structural barriers of violence as a whole. Like, the injury is not just what happens to a person. They've experienced some type of systemic racism that has made them vulnerable to be in a position to be injured, which brings them to our hospital doors, where we have to assess for safety, assess for social service needs, and then start implementing resources and interventions to help them heal from that. And then we follow them inpatient and when they go on, and then we're making referrals as appropriate to community orgs or community violence intervention organizations. And you could go to the next slide. And so we have been fortunate enough to grow over our 6 years to not only expand our case management, but we also now have a medical legal partnership. Our medical legal partnership is the first partnership in the country, and it's called Recovery Legal Care. And it's a partnership between University of Chicago Medicine and Chicago Legal Aid, which is the largest provider in the city of Chicago. And our medical legal partnership allows for attorneys to also be at bedside, in the same vein as that trauma-informed approach and that hand-holding that we as violence recovery specialists do. Our lawyers are taking that same approach to address the health-harming legal needs that our patients have. And so what is that? It's the same thing as the social determinants of health. So whether they need employment or anything like that, our medical legal partnership is helping with that. They're responding to more of the civil needs and overturning like denials for public benefits, ensuring that our patients have the highest awards when it comes to things like 10F, Social Security, income, and SSDI as well. So our medical legal partnership is definitely like thriving, and I'm super proud of that work. And then talking about the work that we do with our CVI teams, like, we value our community orgs so much. We cannot do this work without them because we're very limited in the hospital setting. So we depend on our CVI teams to supplement the work that we're doing. And more importantly, the work that we can't do. Things like even just having that rapport. So we hire from our communities and we want to be representative to our patients as well. But, community violence intervention organizations have always had that license to operate. So they have just a different rapport being in the community with our patients in a way that we can't in the hospital setting. And then we recognize from the medical model the history of mistrust with our patient population, and we understand that, and rightfully so, that they should feel like that. So we recognize, some of those setbacks and hurdles, but we are avid about meeting with our CVI teams, trying to get creative and how we collaborate with them to get them as much access to our patients as possible. But we love the work that we do. And yeah, that is University of Chicago Medicine.
Thank you so much, Christine. All right, next up, we have John Torres, who's a 30-year veteran in community violence intervention and leads programs at Youth Alive. John is the associate director and also a licensed therapist. Supports clients and staff while training frontline workers and presenting at national conferences. His work emphasizes crisis response, trauma support, and organizational strategy. All right, John, you're up.
Thank you, Dr. Simmons. Great stuff, Christine, as well, over in Chicago. Let me start in. As you mentioned already, I'm Associate Director at Youth Alive. We're based out of Oakland, California. And the organization itself has been in existence since 1991. That's when the doors first opened for Youth Alive. I've been fortunate to be with the agency for the last 15 years, a little over 15 years. And first, what I want to do before I jump into the slides is just paint a brief picture. In addition to the intervention bucket of services that I'll be talking about today for this conversation, Youth Live also has two other buckets of programming. One is prevention, the other one is healing. In our prevention work is our flagship program called Teens on Target, which is a high school-based program. It's an after-school program that teaches the students that we work with a 6-session violence prevention curriculum, which they then go out and present to their peers at the middle school level. And so we've been, when that program first started in 1989, we started to work with Castlemont High School. We are still there. We've had a 30-year relationship, 30-plus year relationship with Castlemont. And so that's been, again, what led to the inception of Youth Alive. The students in that program also participate in the second program under prevention, which is our advocacy work. So Youth Alive has staff that is working on different legislation to further resources for trauma impacted or crime survivors, anything that'll support increased resources for the participants, for the population that we serve. And so oftentimes the same high school students are a part, they come along for the ride, either at the local, at the state level, sometimes even the national level, in advocating for, again, those additional resources. So that's our prevention work. In our healing bucket of services, we have two programs as well. One of them is called the Gaddafi Washington Project. This program is our homicide response program. So similar to kind of intensive case management through hospital, this is more geared about helping families navigate in the immediate aftermath after they've been impacted by homicides. So that may mean connecting them to resources with Victim Compensation Board, but oftentimes it's even just navigating the contracts and other really tangible services that are involved in a funeral and burial. And so again, our staff is there for grief support as well. The second program in our healing is our counseling department. Some of these things I'm kind of glossing over because we'll probably get into conversation with some of the other questions at the end. But that would be then our healing bucket of programs. So now, get into the slide. The first one, actually, yeah, thank you. So Caught in the Crossfire was launched in 1994. That is our hospital-based violence intervention program. It makes it the first in the country. And just as we've talked or heard already from Christine and from Kendra, we share obviously the same goals. We have the short-term goals of reducing retaliation, reducing re-injury, reducing criminal involvement, and then longer-term goals about increasing educational attainment, vocational attainment, and really just promoting a positive lifestyle. The target age range for us is 12 to 35, although we have received referrals as young as 2 years old. So obviously the work would look a little bit different, supporting the family rather than the 2 year old. And then on the high end, we've worked with or received referrals for individuals 60 plus. And again, those services look a little bit different as well. But here is kind of a list of the services that we do, beginning with building relationships, doing follow-up bedside visits, kind of those needs assessments, the risk assessments, and then trying to link folks into those resources once the individual goals are identified. The victim compensation board resources, that whole application process, sometimes the appeal process. These are all things that we'll walk individuals with. Housing assistance, we transport uh, individuals to all their appointments, medical or otherwise. Um, we'll try to support with educational assistance. This all is then based after the assessments and what in that partnership with a participant, figuring out what it is that they want to work with at their pace as well. And so again, many things will surface. And as you see, even in counseling referrals. Next slide, please. So what we're also fortunate is that we, as a hospital linked program, and being able to, over the 30 years, really develop different strategies. In 2016, another CVI strategy that we currently operate is our violence interrupter team. So it was established in 2016. At that time, the city of Oakland also had agencies doing street outreach. They made a shift, I think it was in around 2019. And so there weren't, they did not continue, the city did not continue to fund street outreach teams. They did expand on violence interrupters. And so there's several of our agencies. But our team specifically started in 2016. And, it's a specialized team of men and women from the very communities that they're serving. For us, these teams are broken up into three teams: East, West, and Central Oakland. And so they are, engaging in the communities as they're hearing about emerging conflicts, trying to resolve those conflicts, trying to mediate anything that is brewing. And as you see over to the left-hand side, this is kind of a set of their responsibilities. Responding to both shooting and homicide scenes. I will speak a little bit further later on down the road, but this is where we see also an overlap in partnership internally. The violence interrupters, are actually the ones who do the first initial bedside visits. And they do so because they are tasked with doing individual and community safety assessments to figure out, in the aftermath of a shooting or a homicide, what is the pulse out in the community. And so it's very critical for them to be in that first conversation. And so within 24 hours, they're responding. Within 24 hours of referral, they're responding to the hospital. And even in that same time frame, they may go along with Caught in the Crossfire staff, or they may then tag in the Caught in the Crossfire staff again within hours after their initial bedside visit. But this, like I said, for us, it works how we have coordinated within two CBI strategies. I mentioned the mediations that they'll look to do both in the community and schools, and the assessments that they do. And one last thing that I'll throw in about the violence interrupter team, because of no longer having street outreach teams, it left a little bit of a void. The violence interrupter teams do try to do preventative types of activities and building relationships in the communities, not just in the aftermath of a violent incident. And one example of that, for example, is this Saturday our teams are holding a car show and toy drive that they've done for the last couple of years. We were able to distribute last year, I think, impact about 300 or more families with the toys that were given. It's being done in a local middle school. And so it'll be a fun event for all. Next slide, please. The last thing is just really kind of a snapshot of how some of the work and how it kind of rolls out. You'll see in the middle, there's the arrow. This depicts for us the internal coordination that either happens with shooting or homicide. On the top row is homicide, so I'll just leave that for your viewing. I'll concentrate on the shooting, which is the bottom row. I mentioned already violence interrupters, they respond to scenes and conduct the initial bedside visits. And so as they gather their information in doing their safety assessments, they will pass that on to caught in the crossfire. You'll see the second box right to the right of it is then where caught in the crossfire, the hospital intervention piece gets tapped in, the follow bedside visits, the building relationship, all the individualized work that gets done is in that second phase. And then as those needs are identified and we're really trying to increase the resources for the individuals, then it's the referring to those support services that Kendra kind of highlighted, some of them being relocation, counseling, and then depending again on what their individual needs, it could be a whole slew of things, education, programs, vocation, whatever that might be. And I will leave that. That was 30 plus years in a nutshell, I hope.
Thank you so much, John. Next up, we have Tiffany Davis, who is the Injury Prevention Coordinator at a Level 1 Trauma Center in Indianapolis. And Tiffany actually launched the first hybrid HVIP in 2024 in Indianapolis, and she focuses her violence prevention program. She focuses on the sustainability, and she is deeply rooted in her community. Tiffany holds a master's in public health. We are so grateful to have Tiffany present with us here today. Tiffany, I will turn it over to you.
Okay, thank you, Kendra, and thank you to Christine and John too for your presentations. As Kendra said, I'm the Injury Prevention Coordinator at IU Health Methodist Hospital. We are a Level 1 adult trauma center located in Indianapolis, Indiana. And we did launch our first ever HVIP this past April. It kind of began as like a hospital linked model. And shortly after in July, it really became a hybrid model. We are by far, as you guys can tell now, based on Christine and John's presentations, we are the newest program on this webinar today. So we are still learning every day. And I don't know, maybe we will still be in years to come as well. I do want to point out that our trauma center is part of a statewide healthcare system. IU Health is across the entire state of Indiana, and we receive patients from the entire state of Indiana. But when we were developing our HVIP, we saw that 78% of our patients injured by firearms resided in Marion County, and that is the urban county which Indianapolis sits within. So we said for this effort, we are going to focus on our own neighbors and those who live in our geographic region. In explaining a little bit about how our HVIP is structured, I thought it would be best to give you some background as to our city's gun violence reduction strategy. In January of 2022, with mayoral leadership, the city of Indianapolis launched its gun violence reduction strategy. This is something that was developed with guidance and technical assistance by the National Institutes of Criminal Justice Reform after they conducted an in-depth assessment of Indianapolis's needs and resources related to violence reduction in May of 2020. Our gun violence reduction strategy includes a number of items with the goal and successful outcome of reducing criminal homicides and non-fatal shootings by 10% each year. And one of the programs born out of the gun violence reduction strategy that I've worked closely with is the Indy Peace program. This is a partnership between both the City of Indianapolis's Office of Public Health and Safety and then also the Indy Public Safety Foundation. Indy Peace employs a network of credible messengers. They're divided into the roles of violence interrupters, street outreach workers, and life coaches. And these individuals work within Indianapolis neighborhoods. They work with high-risk individuals to prevent and reduce violence. They do wonderful work and they are the front line to community-based violence reduction in Indianapolis. So our HVIP created a partnership with the Indy Peace program in which we were able to have Indy Peace staff come inside the walls of our hospital and sit bedside with our Marion County patients who have been admitted to the hospital due to non-self-inflicted gunshot wounds. Currently, we have 3 life coaches and 1 outreach worker, and they have gone through our hospital's volunteer services onboarding process. And so when they're in the hospital, they are actually recognized as hospital volunteers, but they are able to come into our hospital and see patients bedside. We just started the process of onboarding 2 more life coaches and their life coach program manager, all Indy Peace employees. And so as our program expands into other areas of the hospital, we'll have flexibility to onboard more Indy Peace staff as well. So the way that it kind of works is when the trauma team identifies an admitted trauma patient who, one, lives in Marion County, two, has experienced a non-self-inflicted gunshot wound, and three, is familiar with time and space, capable of consenting to the HVIP, they will receive information about the HVIP and they'll be asked if they would like to participate. And upon receiving consent, then a referral will be placed to the NDP's program. And then NDP staff report to the hospital within 24 hours to see the patient. In once bedside, the NDP staff assess safety, retaliation, social determinant of health risks for the patient. They can connect to resources right away, but they also begin a triage process to determine if the patient would qualify for the NDP's fellowship. And the fellowship is an 18-month program that involves intensive case management. If the patient qualifies for the fellowship, they may enroll into it, and then they will begin to receive one-on-one services with their life coach. And then simultaneously, what really has made us a hybrid program is simultaneously to the launch of our NDP's partnership, our hospital applied for and received funding that hired a hospital-employed licensed trauma therapist for the HVIP. Additionally, this funding has funded barrier buster assistance dollars for patients, professional development for the frontline staff, such as violence prevention professional certification, program supplies, program needed food, program evaluation, and group care as well. Next slide, please. So it is both our partnership with NDPs and our hospital coordinated grant funded services that is what makes our program hybrid today. And so this slide just shows a little bit of the responsibilities of each party. It shows how we've kind of shared our work and split our operational costs and responsibilities since we've launched, which was in spring of 2024. I do also want to acknowledge and thank the CAPS Coalition. I don't know how familiar people are with the CAPS Coalition, but they identified Indianapolis as a priority city for their first round of CVI technical assistance and training. We were certainly able to benefit from that. So we were blessed to receive free technical assistance and reduced training costs along the way as we were developing our HVIP. So just another stakeholder that we partnered with and benefited from. And then in terms of us being integrated into the CVI ecosystem within Indianapolis, by leveraging a relationship with NDPs, we gained access to a larger network of community-based organizations and resources for our patients. Our patients have benefited from using the NDP's barrier buster process that was already in place prior to the launch of our HVIP. And we gather together NDP staff and hospital staff on a weekly basis to discuss program updates and patient cases and updates as well. We have involved both NDP staff and hospital staff together for program evaluation. We also have connected with our local community college and university for some of that program evaluation. And then as the program coordinator, I was invited to attend weekly post-shooting review meetings. So this is where weekly shooting incidences and their subsequent necessary referrals are discussed. And in 2025, our HVIP, along with another HVIP in Indianapolis, will be subawarded funds through a CVI grant that our local law enforcement was awarded. So thanks to our local law enforcement for including the hospital HVIPs in that grant application as well. So all of this is really, I think, shows a good collaboration within Indianapolis, and we are working to improve that each day. I think that's all I had to share right now. Thank you for being a part of this webinar and allowing me the opportunity.
Thank you, Tiffany. John, Christine, great work happening. Thank you so much. This is amazing. Yes, you all ready to have some discussion about this great work happening? That's what I think people want to hear now. All right. We can stop sharing slides now. Yes, let's get into the discussion. All right. Well, I had a first question, just to really start really diving into some questions about, how you actually do some of this work. So one of the first questions I wanted to put out there, and it's kind of a two-part question. So I really wanted to know, and I'm actually going to start with you, John. If you could answer this question first, I want you all to answer it. But you kind of talked about this already. How does your program really get into identifying the high-risk individuals, and what does that assessment look like? You kind of talked about this a little bit in your presentation.
Yep. Let's get this started. So uh, again, I know it's a two-parter. So how do we identify? Obviously, the initial referral that comes from the hospital. And if I didn't mention it, we work with three kind of trauma centers in our area at the moment, but Highland Hospital is the main level 1 trauma center. So we have a whole system that's embedded. When we get these referrals, obviously we're talking about gunshot victims. And this is where I think for us, this twist of having the violence interrupters be the first ones to come into a safety assessment really helps us in identifying, because they're navigating from two sides. One, about an individual. Is this person, asking questions such as, were they the target of the shooting? Is it safe for them to go home? And because of their networks of working in different communities, they're trying to piece together the entire puzzle. Do they know who this individual is? Do they know who they are associated with? Can they connect from what we've already learned about a shooting incident, right? And start to piece it all together. And so that's one way with the direct questions, but it's also this knowledge and overlap between what the VIs are doing out in the community, and then again knowing that there was an injured client that is coming, to us. Now, again, the VIs have long-standing relationships in their communities, so oftentimes they're able to really like cut down any kind of trust or relationship building kind of barriers, and they're really able to get to folks. But the reality is sometimes people may be shut down from the beginning. So it's kind of twofold. The initial wave of questions is, again, we're trying to piece together what the full picture of an incident of a shooting is. But then as the caught in the crossfire staff, those intervention specialists continue to do work, it may be that we're learning other tidbits of information later on down the road as that relationship continues to get built. And so if again there's conflicts to be mediated and stuff, the VIs will then get brought back into the fold and start to again work collaboratively internally. But direct questions, really assessing in that time, and then following up, and because of the knowledge and the networks, that extended networks that our VIs have in the community, I think that's how we work again initially to identify those high risk individuals. And like I said, with those initial questions, we're also conducting those safety assessments initially. Sometimes there's immediate relocation needs that need to happen. Sometimes those relocation needs may surface later on, again, as then the hospital, or the HVIP staff are working with folks. So it's really fluid for us, and yeah, that's how it's worked for us.
Thank you. So it sounds like it. Yeah. So it's a two-part thing happening simultaneously. All right. Thank you. Thank you, John. All right. Tiffany, can you talk a little bit about your process?
Yeah, sure. When it comes to safety assessment, we rely on our partner NDPs to do that. Essentially, although we do have a therapist who I think does collect a lot of safety assessment type of data when doing her therapy. But the NDP's program does have criteria that they use specifically as they're triaging for the fellowship to see if this person is very high risk. And then if the person is very high risk, then they will hopefully successfully enroll them into the fellowship. Not only do they look at specific criteria, but they receive referrals from multiple avenues, not just the hospital. They receive referrals through the city, through the weekly shooting review that they collaborate with law enforcement on. So they're able to receive information about individuals in our community from multiple avenues that might put them at higher risk, showing that they are connected to certain incidences or they've been shot previously, and or siblings have been involved in gun violence and things of that manner.
Thank you so much. That's a lot, a lot. Thank you. All right, Christine, how about you?
Yes, ours is so similar to what both John and Tiffany said. We do have a safety assessment that we do with our patients, and we want to hear from them first and foremost. If they feel like they're high risk, we're intervening immediately. We do ask a litany of questions just to assess if they're safe. Like if you've ever been injured before, was there anything similar between this instance and the last instance? Do you know anybody that has been injured before? Because we know if you know somebody, the likelihood of you being injured, increases. So we do our safety assessment because we do a lot of meetings. Like we are in rounds. We talk about our patients in rounds. So we'll go through and talk about high risk patients, safety concerns, barriers to discharge, those different things. Like if somebody is injured at their home or injured living with a loved one, we want to address those different things so that they have a safe place to go when they leave our hospital. And then our CVI teams let us know too. So we're engaging with them. And sometimes even before our patient get there, they'll let us know like, man, it was crazy at the scene. Like you have such and such coming your way, just trying to give you a heads up. And so we're prepared to know, what's going on. So talking to our CVI teams has also been super helpful, and just even exchanging that information back and forth. Like if we know, we're trying to tap our CVI teams as well too. So it's a lot of those coordinations. I think Tiffany also mentioned the calls. We have high risk intervention calls in some of our neighborhoods that are riddled with more violence than others. And so we're talking on those calls, and we meet with our CVI teams too weekly to discuss patients and interventions and referrals. So high risk patients are definitely discussed during those calls as well.
Yes, it sounds like there's just a lot of coordination that has to go into ensuring that, that high risk individuals are supported when, you really want to make sure that you identify the right folks and to be able to wrap your arms around those and make sure that they have the most successful interventions and keeping them safe. You just brought up something that kind of leads me into the next question, Christine. So I'm going to come to you again, come right to you. What do you think are some successful strategies in terms of initiating partnerships with other models in the CVI ecosystem?
I think, of course, vetting the organizations. Like I wouldn't refer anybody to an organization that I wouldn't, if I can use those services myself. So I think everybody takes that approach with just being careful about who you're referring to for what. Making sure that it's an appropriate resource for the patient and their families, because what happens is you're giving a patient a lot of different things to like look into, or numbers to call and stuff like that, and that could be overwhelming. So you want to make sure that you're giving them the appropriate information, and then being a support with them. Like if they've just been injured at the hospital and getting home, sometimes they may not have the means to be able to make it to an appointment. So you as an advocate, you can go with them and be there with them as they're activating these services and holding their hands throughout the process, and helping them to understand that if this is not a right fit for you, this organization, like it doesn't have to stop here. Like we can help you find another organization that's appropriate for you. So I think just being cognizant of like where you're referring patients to, and making sure those partnerships are airtight. Like if you are offering some services, don't overload the patient with other organizations that are offering those same services. Make sure that they're getting one thing from here and one thing from here so that they're not overburdened. And in good faith, like you're trying to help, but sometimes it can be overwhelming.
Yes, yes. And I like what you said, like thinking about, would you go there, yourself? And you really have to think about that when we are working with, working with people in the community, our people, will we go there ourselves? Yes. I think you brought up a really great point. John, with your 30 years, over 30 years, I know you've been around long time. What are some of the barriers that you have experienced when you've tried to partner with other models in the CVI ecosystem, and how would you address them?
Thanks for putting me on blast. Now I feel old. Right on, Dr. Simmons. However, from my seasoning, you know, I kind of go with I start with what Christine, already said. You want to it's a relate. I think it's just like what we do with our participants. It's relationship building. We're trying to build relationships, hopefully get folks on a team that are of like mind and like operation and are invested in the same ways. Yes, there are barriers, right? I think one thing that can happen at times, and it's not to say intentionally, right? I think definitely on as a community-based organization, we try to support folks with everything at times, right? Even if we're not experts in a certain area, but we're trying to because it's the person in front of us and we want them to do better. And so where I was going with it is uh, this phrase of like lane merging, right? And what I mean by that is, you know, for Youth Alive, we're very clear. We're a hospital-based program. We're not workforce development. And obviously, we have some other strategies like our violence interrupter, even counseling, things of that nature. There are some specific things that we feel we've really built and established our reputation and in the delivery of services, and it's what we're honed in. But we know that there are many needs. We're not a boxing program. We're not, again, educational. We're not doing, GED programming or that kind of stuff. So we need to partner, with many other services in order to really serve somebody. But we don't come out here and start to do GED classes or anything. We want to stay in our lane and like to find other folks that are going to, hopefully be in their lane, right? Now, again, the services, sometimes we find ourselves navigating, for example, the Victim Compensation Board application. Anyone can do it. Even individual participants can go do it on their own if they choose to. We just try to support people through it. And by doing it for so many years, we have established relationships with that office and we're able to, when little issues come up, I think help navigate that person through it, maybe even support them in a way that will really link them to those resources. And like I said, and many other agencies may not have all the extensive, 20 plus years of relationship. And sometimes in their best effort of trying to do certain work, sometimes it starts to overlap and muddy some things in there. And in the end, what really ends up happening is I've seen participants, the actual folks, they're the ones that end up suffering because of either a delay in getting linked to those resources when all the while, somebody could have just tapped in with us. Hey, do you guys have this? We're like, hey, yeah, let's take that on, and again, work in partnership. So I think that sometimes the challenge is, like I said, not I mentioned not because it's an intentional thing. It's just that spirit that as community folks, we just want to do everything under the sun for whoever the person important in front, and then that's kind of a trickle effect at times.
So sounds like I have to really understand what it means to collaborate and really have that collaborative spirit. Because I hear staying in your lane a lot over time, and sometimes the lanes get a little crooked and the road gets a little cracked up, so folks got to smooth it out. So I think it is really important to understand, what your lane is so that you can understand how to collaborate, how to best support each other, no matter what, what that work is. Because it's not like there's not a lot of it out there for us to do. I think we can definitely do a lot of it together and we can do more together. If we can't work in silos, if we actually spread it out and actually collaborate and again, clear those lanes up, I think we can do a lot together. Thank you, John. Tiffany, I have a question for you because you are someone newer in the HVIP work, but you came in and did some great work launching an HVIP and building that out. So you got started rather quickly. Question, how do hospitals build and maintain trust with frontline workers who are already doing CVI work?
Yeah, thanks, Kendra. So I think like many issues and challenges, it comes down to consistent and continuous communication between our team and the teams that we wish to partner with, and really just building trust and relationships with them, getting to know the frontline staff on a personal level. One of the things at the hospital, I mentioned in my presentation that we actually, our NDP staff that come into our hospital are recognized as hospital volunteers. So we had to go through the volunteer services department onboarding process, if you will, and that includes background checks. And I had multiple conversations with our volunteer services department around, hey, here, these people are credible messengers. This is what credible messaging means, and explaining what we were doing, why we were doing, and advocating on behalf of our program to ensure that no background check would be a barrier for any of our frontline staff coming into the hospital. One of the things that I learned very quickly is important is providing collective care to the frontline staff, showing them that they're important and that they're the work that they're doing, we recognize that it's tough, and giving them outlets and fun things essentially to do, and to separate a little bit from the heavy work. Providing mental health care is really important to our frontline staff, I understand. And we hired a trauma therapist with our grant fund that she works with our patients and she does great work. But the other thing is that and maybe this is more hats off to her than anything that I did, but has made herself available to the rest of the frontline staff too. And that's been really incredible. So we're grateful for her doing that. And also it's provided benefits to our whole team of frontline staff.
That is amazing, amazing. Similar question to you being, Christine, being hospital-based. Similarly, how did you all build trust within within your hospital, being hospital-based, with having CVI workers? You have CVI workers that are involved in your program. How do you build trust with your hospital?
Yeah, so we are very intentional about hiring within. Hiring from our communities. We want our frontline team to be representative of the communities that we serve, coming from the same neighborhoods, having the lived experience. So we relate to one another on a very like foundational level in that sense. And we actually even have some people that have joined our team from some of the CVI organizations that we partner with. So it's been amazing, and that meshes us together very, very well. I think as a big institution, you would be surprised that U Chicago Medicine is very humble in that regard. Like, we are super dedicated to our community and know that we need our community violence intervention organizations. So we have to do that work. We want to make our team just as much as like have that license to operate as the community violence intervention organizations. So we do trainings with each other. We've partnered a lot and had cross trainings where the CVI team and the hospital response team were all getting trained at the same time. We were understanding the work that each other does. And I think that pushed the needle, threaded the needle more to understand like what it is that we do, what it is that you do, and then how can we work together to do that work. And just like Tiffany was saying, we take care of our own because everybody is exposed to so much of this trauma. We try to take care of each other. Like, if that's implementing peace circles, if that is having those community outings. We similarly also hired a licensed clinical social worker to support our team. Like, they can talk about cases and how they're feeling around doing this work, talk about compassion fatigue and burnout without any leadership present, so they can be as open as they want and not have to have us around. So it's very much so a reciprocal relationship. Like, we really depend on our community orgs, but we want to be representative of our community as well. So the frontline workers that are out on the front lines in the community looks just like the frontline workers that are in the hospital with us on a day-to-day.
That is amazing. And I hear collective care and support for frontline workers. I think that is amazing. John, do you have anything that you would like to add to this point in terms of frontline workers and building that trust?
First, I'd start with Christine, Tiffany. Applaud you guys, appreciate you guys for having that perspective. Oftentimes, that's what it takes, right? Individuals that are committed in that way and can see. And so some of the things that I had jotted down for this, I think it's really having a complete understanding what HVIPs are, first and foremost, that the hospital needs to have that so that they can appreciate, these things about individuals from the community. What does that mean? What does a credible messenger mean? And how that can be so critical in this work. Some things were already said. I think it boils down to communication. I also had written things like, kind of meet and greets or learning. I think learning together, oftentimes you get to see how people's brain work and how really they would address an issue. And you start to really establish kind of that rapport because now you get a better understanding. The one thing that I would also add is really, again, and we're hospital linked, right? So it's a little bit different on here. But for hospitals, I would throw out there to, really engage in the HVIP kind of leadership and to really map out and we're always transparent. We've been transparent, from day one about our data that we're collecting, about the moves that we make, the hires, all that kind of stuff. But the transparency about what is behind the professional development of our intervention specialists, right? Because sometimes folks are going to come in, there's MOUs in place and all that, but that doesn't necessarily really articulate, the HIPAA training, the VPP certification, the ongoing trauma informed care, the vicarious trauma trainings, the first mental health first aid training, motivational interviewing, all these things that are skill sets that the intervention specialists are learning in order to do their work on top of, the communities they're reflecting or where they're coming from. And I just feel like that kind of transparency and engaging in those conversations, are real beneficial because then you get a better understanding from the hospital side what really goes into, really creating and supporting an intervention specialist in the work that they do. And maybe there's even opportunities to, the hospital could say, there's this training coming across, or there's something else. There could be other resources that also could be embedded into that professional development of those intervention specialists. So that would be the one thing. And I agree with everything else, self-care. We also as well got licensed folks to support our staff. I think that's a good common theme amongst everybody.
Yes, thank you, John, for raising that. I would like to think that folks coming into the hospital, the lived experiences is not all for frontline workers. Lived experiences is not all that they have. There's definitely training that comes along and a whole nother skill set and a knowledge base that they have acquired doing this work that helps them sustain in this work. So I definitely appreciate you lifting that. And we have to continue to support those on the front lines in doing this work and continue to enhance the skills that they've already brought to this work. Again, we just have to ensure that we continue to enhance those skills so we can continue to sustain the front line. All right, so let's talk a little bit about those other models in the CVI ecosystem. This time I'm gonna start with you, Tiffany. What do you think are some best practices that you've learned so far, like in doing some of those warm handoffs, like when you're calling other folks to the hospital or making those referrals to like life coaches or to outreach teams, violence interrupters? What do you think? What have you learned so far?
Yeah. Well, our safe handoffs really start in the hospital when our frontline staff come inside. Actually, the first 3 months that we launched, we had our trauma team kind of take the frontline staff to the patient rooms. In one sense, it sounds like, oh, you're chaperoning the frontline staff. It was actually helpful to introduce the frontline staff to those that work on the units to say, we have launched a new program. this is XYZ individual. They're here to see this patient and they're with our violence intervention team. And so there wasn't any confusion between who are you, why are you here, and what are you doing? And we did that for 3 months until we kind of backed away on that. And now I think their faces are more recognized, and we know that the program is recognized in the hospital. So that was really helpful. Additionally, when our frontline staff come into the hospital, they check in with our trauma team first so that they can get more information. When the referrals are placed, the referrals are very vague between, hey, we got a patient for you to see, and might have an age and demographic information that's very vague. So if they check in with the trauma team before going to see the patients, they're able to gather more information about the patient's story before going to see the patient and ask questions and get their questions answered. Another, I think, handoff or collaborative opportunity with other models that we have in Indianapolis is we do have another level 1 trauma center, adult trauma center, and they also have an HVIP. So, if a patient is shot in Indianapolis, they could, especially if they're shot more than once, one time they could go to our hospital and another time they could go to the other hospital. So I've worked really hard to build a relationship with the HVIP team at the other adult trauma center that we have, and building relationship with them, which sometimes has even boiled down to we go to quarterly breakfast, which is something easy, but it builds friendship and it builds connections so that now we can have the conversations that we need to have about collaboration and how we work together. And then the gun violence reduction strategy and all of its stakeholders have just been really open to including both of the HVIPs in the work.
Thank you. Thank you so much. So really being intentional about making sure that you stay connected and build that relationship and have a strong partnership. So it does definitely take some effort, a lot of effort to coordinate that. Yes, thank you. How about you, Christine?
Yes, I think just really honing in on the relationship aspect, and more importantly, honing in on the relationship when it's not in the emergency setting. Because when you get in an emergency setting and it's like the patient is here, it's a lot going on, we're trying to make sure that people are bedside and everything like that. You're not really working on that relationship between you and who you're making that warm handoff with. But when it's not like all, the emergency state, you can really hone in on those relationships and really get to know, like, what is your referral process? What other services do you offer just besides this one service that I know about? How successful have you guys been with, closing out this, like making a closed loop referral, those type of things. And so I think that is important. And then also knowing that the moments that you have can be milestones with patients. I am huge on that because you may only have a short amount of time with that patient or family, but what you do can move mountains in their lives. And when you're working with other organizations, having that warm handoff can just really make it a seamless process. And it makes the patient more readily able to trust whoever the next level of care is, if you know that person. It's not a cold introduction, like I'm not giving you a number to call. I'm saying, hey, Steve over here is the person that I want to introduce you to. Let me come bring him here to the hospital so that he can meet you, he can meet your family. And so this is not a stranger or just a cold call. It's really like you've met this person, you know that I know this person, we've built a rapport, and so you're more likely to build that same rapport with that person. So I think just really building off of those relationships and being genuine, like when you have a genuine concern, it goes a long way. Like you cannot fake this work. It's really human to human connection. So if you're connecting with that patient and family, really trying to understand what happened to them and where they're at, it'll go a long way. And hopefully that person that you're handing them off to also has that same rapport with them, so that they can really help that patient and family.
Thank you. Thank you both. So again, really coordinating and sometimes slowing things down. That's what I also hear, slowing things down so you can really, hear what's going on and understand. All right. So I'm going to shift gears a little bit. And I want to ask you this question, John. In your experience, what are helpful ways to collaborate with like city government, for example, like an OVP or other collaborations or institutions like the health department, things like that? In your experience, can you talk a little bit about that?
Sure. Well, in our case, for example, in the city of Oakland, there is a Department of Violence Prevention. That would be the closest, I think, to the OVP, right? Um, it's interesting because some of our work, I dated it back, like our hospital-based program started before even the inception of a DVP. So some of we've been doing work even beforehand. But currently, they do fund partially some of our work, and they fund other organizations. And so, in some ways, we didn't need to create. It kind of was a part of our funding stuff. Now, I'd say maybe about 8, 10 years ago, I think that version of the Department of Violence Prevention, it was called something else. But they were funding folks and supporting individual agencies. But we actually had pushed on them. Why are we not all collectively, you know, uh, talking and trying to coordinate? And so off of that was birthed, a weekly meeting that now continues to be held with, like I said, ourselves. In the various components, the homicide response, the hospital-based work, and then also with our VIs, and then the other entities, the other agencies that provide violence interrupter work, and other supporting services. We're all at one table. So I think the partnership, just kind of I, I think it was more organic. It wasn't forced, although like I talk about contracts, it was something that everyone felt like it was the thing to do, and we've continued. So it's helped definitely there, on one end in communication and strategy, in how to, maybe hone in on certain areas, raising awareness around potential conflicts that are around the corner. So all of this kind of information. Now, I will say this, um, the DVP has really taken on, and we've, supported them and embraced, and happy that they do, because since they're a city partner, they'll have communications with some of the other entities like law enforcement and the such, so that there is kind of, a little bit of separation between the CBOs and, some of these other entities. We know that there's obviously law enforcement strategies that play a role in reducing violence. And yet we've been able to have kind of the professional understanding that we do and operate a little bit differently. And definitely sometimes the intermingling could jeopardize, especially our staff out there in the community. So being conscious and being able, for people, it kind of fits in that whole lanes that people fit. DVP has been that one to be able to bring information that they may learn from sitting at tables like, shooting reviews and the such. And so again, that's the DVP end. I think the health department, of course, here in Oakland, it's not just the city, but then there's Alameda County. So the public health department sits primarily there. There's some public health entities in the city, but a large part sits at the county level. So we have to engage, as well with other partners, other government partners. And the reality, I think it just goes back to that relationship building. I think Christine said it. We don't want to do it in crisis all the time. Sure, that's going to happen because we know the nature of the work. But how many conversations can we have ahead of time? Can we learn about one another? Can we rely? Can we share information? And I think that's where the critical work, the foundation of how we will operate in crisis is where it's at. And so again, reaching out, if there's new offices, if there's new people, if there's turnover, how do we start making those connections and introduce, ourselves, right? And again, present ourselves as the resource that we are, the partner that we want to be, and start to, discuss again, like how we support one another. Those entities that we talk about, the health departments and all these, are also there, right, to support the residents and their well-being and whatnot. So there is a common, overlap of what we're trying to do. We may look at things differently, we may do all that, but getting all that kind of conversation out and building that rapport then again helps when it comes to that critical moment of when everything is, in chaos. So
Yes.
those would be something.
Thank you. So again, I hear a lot of collaboration. Again, that I keep hearing over and over the theme. I'm gonna have another question that I would like, Tiffany. If you could share a little bit about how you share information with other models and stakeholders regarding community safety, because you mentioned attending shooting review meetings in Indianapolis. So can you talk a little bit about that?
Yeah, we did create an MOU. It's actually a three-way MOU between our hospital, and it's also with our Office of Public Health and Safety, City of Indianapolis Office of Public Health and Safety, and then lastly with the Indy Public Safety Foundation. And so, of course, that has protected us legally in many ways. And in developing our HVIP, that was a necessary but also a time-consuming task that I don't think I realized how time-consuming it is until you get those legal signatures and all the signatures necessary. And then when we go to the meetings, we know that we can discuss about the patients that have been part of our program. They've also, when they consent to being part of our program, they do sign a release of information form. So that helps as well. So they're not just verbally consenting, saying, yes, I'm willing to be in this program, but they're also signing a release of information form.
Great. Thank you. This has been an amazing conversation, and then actually the time has came up on us so quick. This has really been great. And in closing, each of you, is there any advice, something that you want to share with the rest of, any new or emerging HVIP, any piece of advice that you would want to share with anyone? Christine, I'll start with you. You muted.
I'm sorry. Don't be afraid to start small and grow naturally. And do what you can in your capacity at the time. Like when we started, we didn't really have robust case management. We started really with a crisis intervention. And then as we grew our team and was able to have more capacity, we grew. And then knowing our trends, just seeing naturally what your trends are, who's getting the most injuries, what type of injuries. You'll learn those things as you learn and grow. So don't be afraid to start small, and then know that you don't have to do it alone. Javi is a technical training and technical assistance advisor, and so is Chicago Medicine. So we have 6 years of experience. If you guys need any help, please let Chicago Medicine know. We can help you get your program up and running. So let us know. You're not alone. You are not alone.
Thank you. Oh, John, how about you?
I'd start, I think Christine already started, about the patience and starting slow. I think for many of us, we recognize that CVI is a new term, right? And even that is really establishing itself and, kind of really just laying the foundation and what that's really going to mean for many. And so just be patient in learning it. Two, I would throw out along that same term about, CVI being a new term. There's a lot of work that existed before CVI. It's the latest thing. I hope that all the recognition that we've gotten as a part of this really, takes us into another whole momentum and other, stratosphere for really, cementing the work that we've done for so many years, right? But it is a new term, and there was work that existed. And so, just be patient when you're learning it, and yeah, just focus on your lane in that ecosystem, and you'll be all right.
Thank you. How about you, Tiffany?
Well, I can definitely say that they both mentioned starting small. That was kind of where we're still at. We're working with admitted trauma patients right now. Would love to expand into our emergency department soon, but starting small has been the way that we've been able to successfully launch this year and not to be overwhelmed. But my advice is, if you're starting out or getting into this, do your research first to have a full understanding of what already exists. And then I reached out to those people. So reach out to them, thank them for the work they're already doing, listen to the needs. They are the experts, not us hospital people getting into it. And find the champions. There are people that want to collaborate. So when I say champions, collaborators, find your collaborators. It takes collaboration on both the hospital side and the community side. And so I'm definitely a collaborator by nature, and I have championed this work at my hospital, but I couldn't have done it without the same equal, individuals on the other end. So find your champions and collaborators, and then listen. I need to keep saying that. Listen to the needs. They're the experts, and figure out how you can work together to meet those needs.
Thank you. You three are amazing. Thank you all for the work that you do. This has been great. This has been a great discussion. And all of you who joined this webinar today, thank you. I hope that you were able to take some jewels from this conversation. I just want to say, I know we did not talk about anything regarding Medicaid, but I would hope that you would look at the HVIP website and go, there's CVI Smart Hub, that there is a wealth of information there. So we will send out this presentation to all you folks. You'll have this, and also please look at HVIP website. There's additional information there where you can download standards and indicators for more information regarding HVIP. So please look at that. Again, this will go out and you will have all of this information with additional resources. Again, thank you all for joining today. Please follow us on LinkedIn and also on Instagram. Thank you and have a great day. Thank you for being here.